So, Himadi, good morning, and Alpa and all the Deepak who are. So, we are going to speak very important topic, but unfortunately, this should have been learned by all the newcomers especially, but they are busy in the night parties and so they could not come. So, what are the possible factors, alone or in combination, are responsible for endophthalmitis? It is a deadly disease, and if we take simple precautions, we can really avoid this thing which is nightmare for any eye surgeon. So 5 possible factors are there, alone in combination. If we take care of these factors, we can save the eye of the patient. Personal hygiene, environmental surgical supplies, contaminated surgical supplies, faulty sterilization procedures, inadvertent touch, environment. So we will take one by one. What are the preoperative risk factors? This is external examination, blepharitis, conjunctivitis, lacrimal obstructions, and recent immunosuppressive treatment, and eyelid abnormalities. And most important is the diabetes. So we should take care of these things as a preoperative risk factors whenever we are going to operate the case. These are the, whatever I am going to tell you, this parameter, these are the AOS recommended parameters. If you mention this in the court, you are saved. Blood sugar fasting less than 120, random less than 200 milligram %. You can operate any case, there will no trouble for you. Conjunctival culture, history of chronic infection, recently healed corneal ulcer, urine routine microscope examination. But syringing should be done not on the same day. If you have to do the syringing, it should not be done on the same day. If regurgitation is positive, then we should avoid the surgery. What the instruction we should give to the patients? 4 generation broad spectrum antibiotic, 4 to 6 times a day before surgery, and on date of surgery. No need of giving antibiotic preoperatively for 2 or 3 days. Patient should come with face wash, hair with soap, male should come with clean shaved, and they should wear their clean clothes. What instruction you should give to the patient, staff? If biometry has to be done on the same day, use immersion method. Never use contact method for biometry if it has to be done on the same day. If you have a list of 10 patients and they are diabetic patient 1 or 2, you should operate diabetic patient first, as chances of infection are more in them. How to prepare the patient in the OT to save from yourself from endophthalmitis and save the eye of the patient? So clear the brow region and lid margin with 10% povidone iodine. We should not clear only the eyelid. We should clear all around the eye up to the nose with iodine 10%. Then iodine 5% 2 times topically 5 minutes before surgery is more important than giving antibiotic 1 day before the surgery. So remember thinking povidone iodine 10% for cleaning and 5% for local distillation is more important than anything else. Then we should change all the clothes in the OT that we are doing. This scrubbing very important. This chart should be hanged over the washing area because this is not important for you but for your staff to know, OT assistant to know that he has to wash for 5 minutes. Nobody of us wash for 5 minutes. I have myself noted hardly 1 or 2 minutes we take and then go for the OT. So we should give proper time scrubbing to save our more important time later on if infection happens. Iodine liquid scrub, chlorhexidine antibiotic soap up to the elbow we should clean. Gloves should be proper. Dipping is very important to prevent the infection. Should check expiry date and packing whether it is intact of all not by all the supplies. Your assistant should be aware of this thing. Before giving to you, he should check the intact supplies or not and then expiry date. Irrigating fluids, we should note the batch number and we should physically inspect against the light to see any foreign body is there or not in the liquid. Well, most of the time we have found the irrigating fluid is the culprit in infection. Please preferably keep infusion bottle for 24 hours after use. If there is an infection, you can get it checked. Phaco sleeve and tips should be changed after each case, but we are not doing in India. We can use 2 or 3 cases, but ideally it should be changed every case. There is no evidence that using antibiotic in irrigating fluid will help. So we have stopped giving antibiotic in the irrigating fluid nowadays, as moxifloxacin at the time end of surgery we can give. Subcutaneous antibiotic given at conclusion of surgery have been found to reduce risk of endophthalmitis. Intracameral injection of the antibiotic is helpful, must use in high-risk cases at least, but now we are using almost all cases. That Haripriya from Arvind Hospital has a long research of the long 20,000 patients almost that it has helped. Incision should be watertight, and we should manage the complications. If there is a PC rupture, we should do the vitrectomy, at least anti-vitrectomy. We should not leave case as such, because the vitreous tag is there in the wound area, it will cause infection. Post-operative schedule, we call patient first day, 7th day, 21st day, and then we prescribe the glasses and everything. Examination should always be done at least on the first visit on the slit lamp. We are giving topical broad spectrum antibiotic for 7 days, oral only in high-risk cases, especially diabetes, and topical steroids tapered in 21 days. So treatment schedule is almost changed nowadays. Nobody is giving antibiotic for 21 days or 1 month. We give protective glass for some time. If you have a doubt of the infection, you should talk to the patient, relate to a patient. That will take care by the next speaker. And we should institute proper treatment. We should not panic. And we should take the help of other doctors, authorities. My schedule of cleaning of instruments, microscope head, phaco, cautery, should be cleaned daily with antiseptic after the OT, with the antiseptic liquid, that is chlorhexidine, cetrimide solution. We can dilute it and use. It should be duty of the OT assistant. OT layout, there will be discussed detail. I am just taking it. It should be away from the public movement. It should have areas. You are covering it, Amade? So I will be skipping this thing. But most important thing is culture sensitivity. Once a month, samples from floor, walls, OT table, AC, phaco machine, and should keep record. This will save you in the court of law. If there is any problem, infection happens, you can say, my instruments were clean, I have no fault, my OT was clean. So you should keep this. And we should restrict number of persons. A person should not keep moving in the inside and outside the OT. Water tank is very important. Nobody take care of the water tank. We have never gone to the top of the floor and see what is the condition of the water tank. So we should have a small, separate water tank for our OT, because it is an important reservoir of microorganisms and pseudomonas, which is dreaded organism. Advisor to treat water at user end by some means. Water tank cleaned and bleaching powder once a month. It should be documented. I keep a register where so that I know when it was cleaned before. So documentation is very important for NABH and for the court. These checklists are very important. We should have daily checklists. Who checked the preoperative, who checked autoclave strip, who filled the drum of gowns, who checked clarity of injection, who did preparation before arrival of surgeon. These all things are very important just to make the staff aware and that the staff is doing things regularly. This is signed by the OT assistant, then it is countersigned by me. So they are really worried that doctor staff can see it, so they are doing their duty. Who did cleaning of OT after leaving us? Who cleaned equipments? Who put on the air sterilizers? Who checked the anesthesia trolley? Who replaced these all things you can note down, and it should be a register daily after OT. It should be before the OT should be signed, and after the OT you should sign this. This is a weekly checklist. List of medicine checked, who by whom, emergency medicines. IoT check, who submitted autoclave report. We have a register for autoclave report where we keep daily autoclave report. We keep it, there is a strip of the registration will deal here. We keep that strip in the autoclave register. That is also helpful in the court if there's something wrong happens. Who the cleaning are done, who cleaned the walls of OT up to 4 feet. So these all things are weekly checklist. You see, we are not using now, it is not allowed nowadays, the split AC, etc. But if you are having the split AC, then you should clean the filter daily, routinely. Who clean the instruments? The staff hygiene is very important, their nails, and they are closed. They should have no infection in the hood. Installation of autoclave machine we autoclave the instruments, but nobody take care of the autoclave itself. So they are biological indicators to get clean the autoclave. Who checked it at least once a week or once a month? Expiry date of medicines, and then special note, signature of OT in charge and signature HOD. So these things are very important, and we should really check it. The monthly checklist. Who take the swab culture from wall, floor, OT table, and we should keep in the record. And you can check this register once in a month that things are done regularly or not. Who cleaned the OT? Who did in charge check the washing of OT on the last Saturday? So these things are the important things, not for you, at least for the staff, to keep them on their toe every time. Who clean the water tank? And documentation is very important for NABH and for yourself, peace of mind. So these things should be seen, and this should be signed by you. If you take care of all these things, I know your patient will be happy and you will be happy. So just simple precautions that we all know, but sometimes we really neglect it. So we should not neglect it, and then you can save yourself. Thank you.
Thank you, sir, for the wonderful talk. Now I invite the Chief Instructor of this IC, Dr. Himangi Chaudhary, and
Thank you very much, Dr. SATANSHU MATHUR, for this wonderful presentation.